I'm Lee Rickles. I'm the Chief Information Officer at Humber Teaching NHS Foundation Trust. I'm also the Programme Director for the Rickles Humber Care Records, and really interested in some of that IG discussion on the session earlier. We actually are dealing with quite a lot of them type stuff, so keen to tie into them guys. So yeah, the subjects I'm going to talk about is how it's really vital to have accurate data and that foundation for operational management and to join up care. So do you want to move me to the next page, please? Great, thank you. Data or information really is the new oil, as we've seen from social media or just information in general. The recent stock market interesting moves have been have shown how data and information can really squiff or change things. But one thing is really clear: without good data, you really can't do anything that's of any use. And again, the issue is what is good data, and how do you get that data quality? One thing we are good at, I suppose, in the NHS is we have lots of bad data, or bad uncoded, unstructured data, and to some degree that can lead to really bad decisions, or the lack of even knowing that data exists also makes them bad decisions. Now, from my experience, one of the key items you need for good data is actually having a really good foundation. Do you have good systems? Do you have good coding? Can you join that up? Will that support operational services and joint up care? Having that firm foundation, the same as you know, on a house, you'll have really good foundations, or it's going to fall down. Well, why should it be any different from a data perspective? The problem with the foundation side is it's really hard to quantify to people that don't really deal with data and only really deal with the outputs of the data or the reporting layer, the presentation layer. So there is the key challenge of how to articulate the value of good information and good data in a way that that confirms you need that foundation. And also the data itself needs to be consolidated. It needs to be normalized. Are we talking about the same things? Is it apples and apples and oranges or oranges? Or are we in the mix through and God knows what we're going to get stuck with? And also standardize that data set. And in some cases we have standards. We have HL7, we have SNOMED, but we've also got a lot of other areas where we don't necessarily have standards, such as social care. Although there are some standards in the finance world, that sort of gets a bit woolly when you link it into clinical data, and for things like patient level costing or service line reporting, and then you start having guesses and fudges. Now the problem there is you've got a single version of the truth, but how true is that truth? Are we sort of true? Are we really true? Or are we is it just the truth we wish to believe because that's the information? So the key bit is we have got some new oil where, you know, data is really important, but you know, how good is that data? Is it top class? Is it going to make that car go like a rocket, or is it a bit crap and it runs like a you know, a snail and not really doing what it does? But they both basically move. So do you want to move on to the next slide, please? Okay, so the key bit is how do you get the foundations right? So if you're going to really look at that data layer, if you're really going to look at how you aggregate different sets of data, you need to know what systems, what standards you've got, how good that information is. And if there isn't a standard there, you need to determine that standard. Now, internally, we have a gold, silver, bronze standard. And obviously, as soon as you go to bronze, you know you're dealing with something that's got a fair level of ambiguity. But if you've got gold standard, high level of confidence, and that comes down to how up to date the information is, how from an audit point of view in checking of information, is it accurate, and is it timely? It's important for information to be timely as accurate. Also to have partners, and I do feel that you know, as health and social care, we have expertise in some of these areas, but we aren't experts on all the very technical, very data orientated side of things. So you need a key partner. You need to really have expertise that you can call upon to help deal with some of them wicked issues. And one example I'll throw out that straight away is we use Lorenzo, and we use System 1. Now Lorenzo's got a really good back end, really good structured data, not so always SNOMED, but you know, really easy to manipulate. Now System 1, any System 1 people out there, I'm sure can hear you screaming now, if not because of the current issues around the enterprise extracts and how effective they are, but also with the level of data you get. And you get it, you might be one organization, but you get your extracts per unit. And we have 42 units, all of which will have some level of duplication, do slightly different things such as community hospitals, minor injuries, community care, even health navigators. So the challenge there we had on getting getting it right and getting that high quality is, how do we take all that stuff we get from somebody like System 1 and get it together and do the items as said earlier. So how do we get them disparate data sets? How do we pull it together? And that's just on one system, and normalize and standardize and get that in a consistent format that the one patient record includes the information we need. It'd be really good if TPP could do it straight away. Maybe they will get there soon. There is some interesting stuff they're doing, but realistically we need to do something now, because unfortunately we need to provide care now, not in 6 years time. So that's where using other tech organizations, other suppliers, other partners, and we work very closely with InSource, really come up with that way of dealing with them data feeds, and it's really works well. We have been running with it for a few years, but by getting that data normalized and together just makes the whole process easier, especially because when we're linking Lorenzo data, so other clinical data, but also other disparate bits of data. So we also have ESR data, staff data, you know, roster data, finance. So all these need a level of consolidation, and a lot of these do not have necessarily really good standards. So there is a level of translation we need to do, which is fine as an individual organization, but later on in the presentation I'll touch on where we may be going and what impact that might have from an ICS perspective as we're moving into a brave new world. Do you want to move on to the next slide, please? Okay, so we've got data linked together, but we do need to use it. It's not for the sake of actually having it. One bit I missed off here, and I will touch on that, is the bane of my life, but understanding performance needs to be accurate, needs to be absolutely timely. I mean, we've got the situation at the moment with COVID. Obviously, hopefully we're coming out the back end of that, but during the real busy and hectic times of COVID, how do we make sure that we've got the information that says that we've got feeding from our core data and presentation layer, that we've got the right staff at the right place? We're dealing with where we have patients that might have COVID to then isolate and or move them into the appropriate setting. We do mental health, CAMS, learning disability. So people that may not be physical, but you know, just people, but have slightly different needs and ways of supporting what they do, medium secure as well. So if we've got that accurate data and we know it's good quality, because we at least understand the standard at quality, whether it's gold, silver or bronze, we can really make some good decisions and do performance. Now the other benefit is it helps on contract reporting. Absolute bane of my life, hate contract reports. We create them all the time. The value is probably limited, and that's really something I would probably say we need to move as an ICS, and how we deal with that data layer at that point. How we support decisions. So we've got things like PLICs, patient level costing, service level costing, but also benchmarking information. So a lot of the information we have to be high quality, we need that to be in benchmarking club or model hospital and be accurate and realistic and consistent. We then have the challenge around definitions. We all have the problem of definitions, don't get me wrong. But you know, that's supporting decisions, which then informs how we provide services in 6 months or a year, or even 3 months, or in COVID next day, is really important. Because again, if that data's not very good, why do we think we're going to change or improve services because we're not using good data with a good data foundation? You know, it's obvious. You know, if you don't know what money's going in and out your bank account, then funny enough, you might get in a bit of debt. The reality is the same. If you're not sure what you're actually doing from an activity point of view, or where you're getting good outcomes when you change services, not just counting numbers, counting widgets to some degree is a bit of a waste. How is that improving patient care? How is that getting better outcomes? So did that child that was in that CAM service actually go to college, university, and become a really valued member of society, or are they still in the system and we need to do something else? The final one on there is risk. So what we have got, and this ties into performance and decision making, is using that information is how are we making sure we are managing the risk. And the risk is, especially during COVID, how are we making sure that if we're increasing, if we get more referrals in for children and young people or CAMS, which is happening, that we are really responding to them high risk patients. How are we making sure we get that care as quickly as we can and as appropriate as we can? And that is really based on having really good information and also having really good decision and understanding the performance. Them three things are so intrinsically linked that, you know, without one, the other one doesn't work. Oh, it's gut feel. And to be honest, gut feel is not the best way to provide patient care. And I would hate that anybody ever considers doing that. Can we move to the next slide, please? So now I start from the beginning. So ICS is, anybody who's read the white paper and the consultation will see there's a big need to move to that wider data set, that population health, preventive care agenda. And although, you know, I'd say as an organisation I've got a good set of data in my silo, the real way we're going to make a significant change to our population is by how we aggregate all that data together. Now, what that really means in practice, to get that holistic view of the resources, the estates, equipment, it's some of the fudges that we may have put in the early days, otherwise translation tables, really need to get agreed at scale. It's no good everybody has a different interpretation of staff data. It's no good that everybody has a different interpretation of how you put risk information or how finances work. If we're going to have a true understanding of what's the cost, what's the impact, where do we, what's the best place to use the public pound, and also potentially, even if we've got that wider set of data, how do we create digital twins? How do we do that simulation activity? Which again is a lot less painful than doing a whole service transformation. So the move to ICS is going to be really, really interesting. How as organisations we move away from something that's very organisationally biased to how we get that as an ICS level. Which, to be honest, if we're going to have to get a data foundation correct, that's going to be absolutely key. Otherwise, we're just going to carry on working as individual providers, rather than we need to move on to that partnership model. Do you want to move to the next slide? Okay, now getting all that data is, we need to, that's there for shared care. The data we have in the warehouse actually goes into the Rickles Humber care record, bi-directional via messaging. That's the data that saves lives. That's providing care plans, crisis plans. We understand where ambulance services have seen a client that we need to deal with rather than an ambulance, than a paramedic, especially if we're responding to a mental health issue rather than potentially a physical health issue. But, you know, good data saves lives, but poor data probably doesn't help. The other key bit is how we get patients involved in this. Now, patients have a lot of information. They know more than we generally do. And that's obviously I would say is another big thing around shared care, how we get the patients actually putting their data in, actually taking ownership of that data, and making us, holding us to account and using the data as effectively as possible. So I think shared care is also one of them key ones. Shared care, data layer, they're both big ICS ones. You need a good data layer to do that. You need good coding. Otherwise, forget shared care, forget doing any preventive. All we'll be doing is just going with gut feels.